I was tasked with just producing some revision knee cases here, so I don't have any disclosures that are relevant to this, just some funding. I thought the objective would be to sort of, we're not going to exhaust all of this on every case because it's fairly similar, but proper workup. Maybe we can talk a little about OR strategies, equipment setup, etc. And then surgical strategies. We teach our fellows, we teach what we're taught is really revision knees are three things, right? Bone loss management, gap balance, soft tissue management, joint line restoration. And then we'll talk maybe a little bit about fixation strategies. So since Dr. Hansen's first, I wasn't sophisticated enough to do what Dr. Barry's going to do tomorrow and play like bingo, but we'll start with simpler and we'll get more complex. So this first case is a 74-year-old female, primary TK done about 20 years ago. Did very well up until the last year and now came in and saw me with progressive pain, which she locates over the proximal tibia. It's been refractory to conservative treatment. Her exam's there. So good range of motion, stress is fine. What do you want to know next? Sorry.
That's fine. I mean, yeah, all painful knees are going to get an infectious workup, obviously an ESR and a CRP. If they're coming from a distance, we'll probably just aspirate the knees. I have a very low index of suspicion in this particular patient in history, but would at least get the blood test. I may skip the aspiration on the initial encounter, but if the numbers were elevated, obviously bring her back for an aspirate. In looking at those numbers, again, reassuring, consistent with her picture. Before looking at the x-rays, thinking that she's got poly wear, probably some lysis under her base plate and a loose tibial component at a minimum.
Okay. Just really quick down the line, are you aspirating every knee or just using some straightforward CRP sed rate at first?
Yeah, if I have the CRP and ESR and they're elevated, I aspirate them all, obviously. But if I'm similar to Dr. Hansen, if they're coming from far away and it's going to be hard to come back if those labs are elevated, I will usually aspirate if there's any concern for infection. If I know there's like a obvious other problem, I might not. But
okay. Eli, normal CRP, normal sed rate, you aspirating?
Nothing further to add.
No.
Unless there's a large effusion.
Same
Yeah,
thing?
not much else. I think it depends on your level of suspicion.
Okay.
I think the one thing I would add to that is if someone's come back multiple times for a painful knee and the labs have been normal repetitively, sometimes I will do it just to get another data point, but not usually on the first visit.
Okay. All right, so there's our x-rays. So Eric's your case.
Okay.
So,
Yeah, so 3 views, right knee, looks like a CR, total knee, maybe a first generation cementless or just lost a lot of cement in the 2 decades that she's had it. Obviously, the tibia looks like it's subsided. Yeah, so I mean, what am I going to do?
yeah.
I'm gonna pull all the components, keep
Both?
Yeah,
Okay.
I mean, this is a CR femur, at least going PS. And then I guess the questions are, what are you going to do with the tibial bone loss? I think this case would be, a nice one to get some metaphyseal fixation. I'd probably go with a cone and a short cemented stem and probably a PS femur with a small stem.
Okay. So, you work in a place like mine where you probably have everything around, but for maybe people in the community that are doing cases like this, are you having just a semi-constrained sort of revision knee system? Are you going to have a hinge available? Or you?
No, I think you bring up a good point. Different systems allow different increases in level of constraint. I think you definitely want to use a base plate where you can go to, at a minimum, a semi-constrained. Again, there are some base plates that will accept up to a hinged femoral component. I don't think you're going to need that in this particular case, but I still would use, that base plate that accepts a semi-constrained at least.
Okay. Yeah, so I think that sort of addresses a lot of our questions. That's what we did. The bone loss was significantly more extensive than what we appreciated on the pre-op x-rays, and I think that's an important point to people that don't do a lot of revisions. I wasn't expecting to go in with a bilobed cone, 10 millimeter augments across the entire tibia. And then fixation. I took the femur off as well. This person's a little bit younger, older, so we did do a cemented stem on the femur side. So I think we addressed that one. All right. Jeff, yeah.
Oh, I was going to ask you if you go back to the X-ray.
How do I go back?
What's yeah, you can't go back. What's
go
your
back.
threshold for if you're sort of balanced? Do you have any hesitation in going to a semi-constrained with today's implants, or are you very quick to go?
Good question.
Yeah, it's a little bit loose in flexion. Maybe just put the semi-constrained in.
Yeah, so I'll answer it, and then I'd like to hear the answer from you guys too. I think with current generation components that we have in plastics and the wear properties that we're seeing, I have no concern with going with semi-constrained inserts. I think there's a pretty good paper even from one particular company that looked at even primary knees 10 to 12 years out with semi-constrained inserts and saw no incidence of early loosening, which is what we'd be concerned about at an increased level of constraint. Is that different for anybody? No.
No, yeah, I guess my point being that a lot of these revisions, I think it's very hard sometimes to put in the PS, and it's like really has to feel perfect, which I think maybe even in training, some of my attendings were very much PS until it was like pretty sloppy, but I've kind of switched that now I do semi-constrain almost all the revisions.
Yeah.
I don't think it's a bad thing or a issue. You shouldn't feel defeated by putting in a semi-constrained, because if the ligaments are there and it's balanced in 0 and 90 degrees, almost all of these have considerable mid-flexion instability, and semi-constrained will take care of that, and you're not going to risk wearing it out because it's sort of assisting the ligaments, not substituting for them.
Not to sound like an old guy, but I would put in a varus valgus constrained for this type of case every time. I wouldn't even bother going to a posterior stabilized with that amount of medial bone loss.
Okay. Okay.
Thing every time.
Jeff, here's your case. A 72-year-old female, chief complaint of persistent pain and a sense of instability, and these are all cases from the last 4 months. So her surgical history is a little bit more complicated. Her primary was done in 2015. She did have a acute hematogenous infection in 2019, which was treated with a 2-stage revision. And since 2019, she subsequently healed that surgery fine, but really came in with, ever since that surgery, I just have instability. I can't trust my leg. Her incision's well healed, limited range of motion. You can see her stability exam there. So my template only allows for me to go to more than 20 millimeters of varus valgus instability. Let me just, I forget here. Okay, exam. Okay, so her infectious workup was normal, so I didn't include that, okay?
Yeah, I mean, that's the one thing
all
that
normal.
this
We don't have to
history,
talk
I'm
about
thinking
that. Yeah.
infection as a player until you can really prove that it's not with the history of the 2-stage.
No infection.
But assuming no infection, then the issue is obvious. Dr. Beeney told us it's a problem with alignment, that mechanical alignment leads to instability. So, no, I'm just joking. So, instability, and go back one side. So you're saying in the AP plane or in the varus valgus plane?
Varus valgus instability, 20 millimeters with no endpoint.
Yeah, so I'm not familiar with that implant. It kind of has some sort of post in the center that might be reinforced, so this might already be a semi-constrained implant. So I'm guessing there's some sort of collateral issue. I don't see any issues with loosening on these films. Again, not a ton of cement on the tibia. The lateral's got a little bit of something maybe around the stem. It's kind of interesting that this was after a 2-stage. That wouldn't have been my tibial fixation choice. But yeah, I'm gonna go with there's probably some issue with the ligaments or the overall balance, and so plan would be to go back and try to either see if there's still any ligaments left or have to increase the constraint to a hinge.
Okay. Yeah, that's sort of I wanted to highlight this. I mean, I think on the lateral there's a lot of suspicion for that tibial component. There's some fairly significant radiolucencies that are hard to appreciate on our screen, but hopefully you guys can. But yeah, this case I really wanted to illustrate. Oh, sorry, there's her labs. But yeah, this is something that Dr. Ries taught me when I was here, 12 years ago. If there are no collateral ligaments, at least what he told me, you have to go to a fully constrained knee. Or if you think you're fooling yourself, if you think you can get in there and do a semi-constrained knee and that it's going to last. So yeah, we took everything out and went straight to a hinge. You can see that I didn't, but the fellow probably perforated the tibial cortex there, a little bit of cement extruded, but the nerve and everything is fine. So fully constrained revision implant for lack of collateral ligament integrity.
Yeah, the constrained mechanism of the CCK is a piece of plastic to give it varus valgus constraint, whereas this is a metal hinge. And it's just not going to withstand for a completely absent collateral ligament. We've learned that lesson over and over. So you just have to bite the bullet and take everything out and do this.
I will say I've been burned not burned, but just pleasantly surprised a couple times when there is a loose tibia. Sometimes that exam can be crazy lax. And so if that component was truly very loose, sometimes you can be fooled on the exam a little bit and maybe pleasantly surprised once you get the implants out and some spacer blocks that there is a good MCL. But yeah, if there's no MCL, I don't think you can reconstruct that without a hinge.
Okay. We'll address some of the questions I had on the first slide, I think, with this next case. This is a 48-year-old who had her primary done in 2016. So she was only 41 at the time. Reported that she did very well without issues, had a fall in March of 22, at which time she sustained a periprosthetic distal femur fracture, sort of lateral condyle that was treated non-operatively. She was then sent to me earlier on in this year with a complaint of progressive deformity, which she said was knock-kneed, and she noticed that her foot was sticking out to the side, sort of externally rotated. She said she walked like a duck. Her incision was well healed. Her range of motion stayed there, Eli. Had a partially correctable valgus deformity of about 25 degrees with a stable endpoint on her MCL. And make sure I don't fast forward. There's her infectious workup. We already went through that. So I'll get to her x-rays here. Here's her x-rays.
So it looks like on her alignment films that she's healed into a valgus deformity. It's hard to say. The tibia looks okay on that tibia side there. On the femoral side, it's hard to say if that's, frankly, you said she's walking on it without any pain right now? It's just the deformity that bothers her and the rotation?
No, she has pain. She doesn't walk well. No.
It's hard to say where was her fracture?
It was a lateral condyle fracture that.
Okay, so she compressed down into
Yeah,
it, into
yeah.
that deformity.
Yes,
Okay, that's
yes.
making a bit more
Yep.
sense now.
Yep.
So with this, and that looks like a RP primary tibia, correct?
Agree.
Okay. So on this type of scenario, you're going to have to go up, you have to revise your femur, and then given that you're going to need to go to most likely a higher level of constraint, in my hands, I would be, whether I'd keep the tibia or not, I might actually try to keep the tibia in this scenario, but I'd have everything ready to go forward to to revise the tibia with that higher level of constraint, because I just don't think that, how old was the patient?
She's 47 now.
All right, 47, the tibia's coming out. We're going to change that to get a higher level of constraint, because you're definitely going to need to get a varus valgus constrained for both sides, in my hands.
Okay. So before I go on to what I did, I thought this would be a good opportunity to sort of, we'll start with you since it's your case, but what are your standard methods of fixation and we'll call it two-component revision surgery? So tibial fixation and then preferred femoral fixation in revision settings.
So you have to get fixed, in my hands, you have to get fixation in two zones, zone 1, 2, and 3, joint line, metaphyseal, diaphyseal. For the majority of patients, you can get pretty good fixation in the joint line and in the metaphysis. So whatever your metaphyseal choice is, in my hand, with my system, it would be a sleeve, but a cone is completely appropriate as well. Same thing for the femur as well.
Cemented stems on both sides, or cementless, or
Cementless. Cement just for the joint line, and for your zone 2 fixation, cementless.
and then cementless stems.
Short cementless stems, and if I'm worried about my fixation in zone 1, then I would go to a diaphyseal engaging stem in zone 3.
Gotcha.
That's my standard algorithm for these.
Dr. Ries?
Not a lot different. I think there is some intraoperative judgment depending on the level of constraint you've got. The more constraint, the more fixation you want. So if it gets up to a hinge, probably a little longer stem and less of a threshold to use cones. I think the tibial cones have kind of evolved from filling bone defects to providing long-term fixation, so that and the tibial cones don't require removing much bone. The femoral cones generally do, and the femoral fixation is less of an issue. So I think almost all of them wind up with a small tibial cone for fixation, and longer stem, and maybe a femoral cone if it were added constraint or poor bone quality.
Eric, anything different?
No, I mean, I talked about the first case. Sometimes on the femur, I'll do a longer cementless stem like Dr. Ries.
Okay. Jeff?
I'm short cemented stems pretty much on both sides all the time, and then I almost always will do a cone on the tibia, and that's for the long-term fixation, not necessarily for bone loss. And then on the femur, I'm cones kind of as needed, depending on what the bone quality is and what my distal fixation looks like, bone quality looks like.
I just have one comment about the stem length and cement, which is something the fellows over time have noticed. And they asked me about this once, how long of a stem do you put in and how much cement? And I said, well, basically, it depends how close you are to retirement. If you're in your first 5 years of practice, you're going to just put a little bit of cement on there, or maybe a short one with it cemented. And then if you're in that middle 10 years, it's a little longer stem and a little more cement. And then if you're within 5 years of retirement, you cement the whole thing.
Yeah. Yeah, I bring that up. When I was here for my fellowship 12 years ago, we sort of were looking into this, and you have straight cementless fixation, hybrid where you're cementing one side or the other, or fully cemented. The literature at that time would suggest that basically, end result aseptic loosening, any three of those strategies are fine. About a 10% rate of aseptic loosening at 10 years, about 1% per year. I think the cone data is coming out now. We're getting midterm results on cone fixation, and I think that the fixation strategies for revision knees are evolving. I would agree with my colleagues here. I think cone fixation for zone 2, long-term ingrowth on the tibia is my standard now with a short cemented stem. For me, before I show the x-rays, I don't like digging cement out of the femur. It's incredibly difficult. There's no good easy access. Anyone that has ever attempted a scaphoid window as it's drawn up in textbooks, it doesn't work. By the time you expose the anterior femur and then take a little chunk out of the femur, it's like a loose piece of bone, and it just falls on the floor. So digging cement out of the femur for me, I think, is incredibly difficult and morbid. So I tend to lean towards cementless fixation on the femoral side and going long. So that.
My counter to that would be, why are you taking it out, right? And so you'd be taking it out in probably situations where it loosened, so it should already be loosened easily.
No, just the stem comes loose from the cement.
Nah,
Okay, all right, sorry.
Or it's infected, and if it's infected and you have that much implants in there, I would probably push towards washing and washing and washing as opposed to a two-stage, based on some of the stuff we've done. Or it breaks, and then it's already out and loose, so just the counter argument to that cement.
I think if you're going to choose, and please comment if I'm telling the audience something wrong, but I think that we now know if you're going to use cementless fixation on the femur, this is my opinion, you need to go long. You need to get to the diaphysis in revision settings. If you don't, there's an extremely high likelihood of failure if you end your stem in the metaphysis. So I push it quite a bit, and maybe that's wrong. I don't know. Whoever's following me will get to find out at my practice.
I agree with that, with the caveat that if you're going to get zone 2 fixation, similar to like you did here with your tibia, then you wouldn't have to go as long with that one caveat, which I don't know. this doesn't look like there is much room in zone 2 for something in this particular patient. And sometimes there is no room. And when I'm in that scenario, I did exactly what you would do here.
That's a good point. I think that depending upon what kind of metaphyseal fixation, whether it's sleeves or cones, I know my particular system, they've modified the cones recently, so the femoral cones that they've come out with now are much better than the first iteration where you basically had to remove almost the entire condyles to get a cone in. So
That's true. Even on the sleeve side, sometimes they're too big.
all right, so I think we did an okay job correcting that big distal lateral augments on that to try to get her out of valgus.
Do you want to talk about some tips and tricks we have for like getting components out, getting cement out? Because that's the first step of the procedure, right?
Yeah, can we go back a slide? I'm sorry. Yeah, why don't we go down the line? What are you bringing to the OR to get that out? Do you use specialized equipment? What are your tips?
So I think it starts first with your soft tissue dissection, right? And so you're obviously going to extend your incision. You're going to, clean up the gutters, recreate your, or do a synovectomy, clean up your gutters. And then most importantly is getting that infrapatellar scar all the way down to the tendon. And that really will help move your extensor mechanism out of the way. And then for something like this, you got an RP poly. You want to get the poly out first, so you put a osteotome underneath it, and then saw the post off, and you can slide it out. And then in terms of tools for removing components, I tend to use a little microsagittal saw and flexible osteotomes. There are a lot of proprietary osteotomes where have nice curves that you can get to the posterior condyles, and you can go through the notch. You can get around the back of the tibia with those. And then I think very important to just hit axial force when you're taking out your components on the femur, so you don't break a condyle off if there's a little bit of cement bone fixation still. And then for the tibia, sometimes you just can't translate it far enough anteriorly to clear the condyles because they're stiff and you're trying to get it out. So I don't hesitate to use a saw and cut off the posterior femur, knowing I'm going to augment it later, and that will allow me a straight shot to hit my tibia up and out safely without creating an iatrogenic fracture of the femur. Those are some things.
Okay. Any other different
No different.
tools?
Sometimes I'll use a two-sided recip saw if I'm trying to go faster. And on this one, I'd probably take a little more time on the lateral side, given that old fracture. And it looks like there might even be a fracture line extending across the medial side that might be healed. So really take my time on the femur so that I'm not taking the entire condyles off.
Especially in a 47-year-old, right?
What's that?
Especially in a 47-year-old.
Yeah, definitely.
I find a jiggly saw pretty helpful. I really
Jiggly?
like that a lot for the femur. And then just generally speaking, using my bigger tools or the tools that I have more control with, such as like a regular osteotome or the big saw first, and then moving on to either the flexible osteotomes or the smaller tools. And I find that helps move me along a little faster.
Okay. Mike, any other tools?
Not really much more. You can tell all these guys are well trained. I think that what Eric started talking about with the exposure, and I kind of like hearing that, because it's not like a primary knee where you expose it, you put in retractors, and then you just do it. The exposure sort of keeps going on and on and on through the case. And you take out what's the easiest thing first, the insert, like he said, and then you sort of redo the exposure all over. You find some more scar tissue in the gutter, and then you have exposure of the femur and use the high-speed tools, reciprocating saw, maybe the pencil tip, before you start whacking on it. And then the femur comes out, and then you got a little more room to get rid of some more scar tissue, and then you can start to see the tibia. In the posterolateral corner of the tibia is the hardest thing, because you're retracting the femur, and you can't quite get back there, and then you take out the posterior capsule, what you can see, and then the tibia kind of comes forward. So you keep sort of picking away at things and try to separate the implant from the cement and whack it out, and then take the cement out in pieces. And I think just in general have kind of an intuitive feel for how heavy of a whack you're willing to give stuff. And if it doesn't go, then you got to, go back to the power tools and get around it a little better, expose a little better, and be patient.
Yeah,
And-
good stuff.
The other teaching point I often make is, looking at the cement mantle. Say if a tibia subsided into varus and that cement mantle is now heading laterally, as you're using your cement removal devices, just be cognizant of that false pass that you may end up going through if you just follow the cement mantle. So you might have to, angle your burr more medially, anterior, posterior, in the sagittal plane, just so you can get your cement out safely and then sort of establish your trajectory for your subsequent reaming.
That's a good point. When I was in training, Keith Faring, who's off golfing or drinking or something right now, but he used to always take a burr, and as soon as you got the tibia out, would just go straight down the canal with a burr and just get all that stuff out right off the bat, rather than having to work with a the hook or something like that. Yeah, and it does work really well, especially when you're going to be doing a cone or something like that afterwards. You're going to be getting rid of a lot of that bone. You don't really need to save the central stuff, so you can be a little aggressive there.
That was the only thing I was going to add.
Yeah.
'Cause I'm a big fan of the Onspach and burrs, and that cement plug that's down there is sort of way down there. And I tell the fellows to go ahead and open up the metaphysis, like really see it. Don't try to find it through the little hole. Open it up, get rid of that bone. You're using a cone anyways, and then you can see it better. So, and exposure, I like your extensive.
The other thing,
extensive
I
mechanism.
think to just talk about is extensile exposures to the knee.
We'll get there.
Okay.
I don't have any of those in here, but I think we'll get there in a second. Yeah, other approaches. So there's only 2 more cases, so we can bring that up for sure. So this person is a 67-year-old male, a total knee done in 2008. Mike, he did great until the last year, and then started having a bunch of issues. And he came from somewhere else, and he had pain, and they didn't bring any records. He said they did some sort of an operation, like once or twice or something, and then he had some antibiotics, and his pain's been persistent, and now he's noticed this draining sinus.
It's well healed except for the sinus.
Yeah.
Okay.
Well, the entire incision's healed, except the sinus is actually not part of the incision. It's actually on the proximal medial tibia. So the incision is healed, but his sinus is like way distal, like 2 or 3 centimeters distal to his incision. All right? So infectious workup. There we are. I actually cheated, so we'll move on. His infectious workup was actually normal, but he had a draining sinus tract, but I didn't want to confuse things. So this guy's infected, so I wanted to use this case. Like, what do you see in those x-rays? We know it's infected, but x-ray-wise, if you just saw the x-rays, pretty concerning.
Yeah, I mean, he's got a big something or other going around the tip of the tibia, so that's an infectious cyst. And, it sounds like it's been this smoldering infection that's kind of been ignored for a long time. And it'd be nice to know what the bug is, but it's all going to have to come out and put a spacer in and, have the ID guy figure out what to give him and stuff like that.
Okay. So I wanted to use this as an opportunity we can maybe briefly touch on revision exposure things. I don't think we have to get too fancy here, but what about spacers? What are our spacer options in 2023? What do you all prefer to use? Go ahead. Yeah.
So when I was a resident, everyone was really big on the molds. Then as a fellow, I was exposed to the idea of using real components. And then when I started as an attending, I calculated the cost of the real components. An old all-poly tibia, or just take a polyethylene and make an all-poly tibia with a primary femur, was cheaper than molds. So for my primary articulating spacers, that would be my spacer of choice, with an antibiotic dowel that I would make with some Steinman pins shot up and down the canal. For the type of case that we're talking about here, where we're worried about our soft tissue coverage and probably going to need a flap, it would be a static spacer that could either be with a fusion nail or more cheaply with a trauma tibial nail put up and down the canal with a nice sort of wad of cement in the middle.
Could I just want to interject for a minute? I think you ought to combine this question with the cement mixture, because sometimes that influences it. The
Sure.
pre-made stuff comes with a certain amount of gentamicin. So along with this, what do you use for your cement mixture? Is it the same for everybody? And how much antibiotics do you put in the cement, and what's the concoction? Because people are sort of all over the place with that.
Yeah. So cement, what?
Cost is an issue always. The cost of a antibiotic loaded, preloaded cement in my hospital is about 10 times the ones without the antibiotic, and I haven't really seen any data that it does better to have something that has gentamicin in it versus me just adding the vancomycin and the tobramycin myself. So I put 1.2 grams of Tobra, 1 gram of vancomycin per bag. That's based off of some of the studies that just show that after 5 days, the antibiotic's gone anyway. So why put more antibiotic in there, put the patient at risk for other type of complications, kidney failure? But I'm certainly, I think, on the lower side of that spectrum, I imagine.
Yeah. Yeah. I mean, I think a couple things there, right? That's a low. That's not enough antibiotics, in my opinion. I'm using. So let's just assume this is I think I said the staph epi. It's sensitive. So I think one important thing to know is what kind of cement are you using. That's important. So if you're using one specific kind of cement, it's actually elution characteristics are higher, so you can't put as much cement antibiotic in that, or you can have an acute kidney injury. I use a simplex cement. I mix it just like what was said, but I use 3 grams of vancomycin and 3.6 grams of tobramycin per package of cement. And a knee will get typically 3 packages, 1 for the tibia, 1 for the femur, 1 for the dowels.
Yeah, I think that some of the people here wrote a paper recently. I don't know if it's published yet or if it was just a poster right now, but the amount of cement or the amount of antibiotic does matter, and we looked at ours and had kind of conflicting practices, and having less than 2 grams of vanc was predictive of failure. And so if anything else, having enough vancomycin in the cement. My practice is I use a green colored cement, which is less than, you put less in it than the white colored cement. So the green one, I do 2 and 2, so 2 of vanc and 2.4 of Tobra. If I know the organism is gram positive, I'll sometimes swing it to 3 and 1.2. Or if I know it's gram negative, swing it the other direction. But yeah, it matters what the cement is in terms of what amount of antibiotic you can put in and what you're going to get out of it. And the only other thing I'll add that is this year and next year you will start to see some of the early data from the 1 versus 2 stage. And so in this patient, I think what is a big differentiator in terms of how this might be treated is where is that sinus and how bad is that sinus? If it's something that is just kind of a little small poke hole that you can excise and easily close, that might put someone like this that's otherwise a decent host with a known organism into a camp that may in the future be a good candidate for a 1 stage. Whereas if it's going to need a flap, then it's obviously always going to be a 2 stage.
Yeah. Eric, articulating spacer at all cost, or are you okay to put static spacers in if you have to, or what's your...
Yeah, I mean, I think the most important point is that the reinfection rate or the infection clearance rate is going to be the same regardless of static or dynamic. And there are some, functional improvements, though slight, for patients who have articulating spacers. So unless there is a contraindication to use an articulating, then I'll use an articulating. And the indications for a static are, I tell the residents, soft tissue deficiency, that's either anterior skin soft tissue deficiency requiring a flap, that's ligamentous incompetence, either collateral ligament or extensor mechanism, and that's major bone insufficiency in the form of, both either distal femur or proximal tibia.
Okay. Yes, this person's sinus was not a big deal. It was like Jeff sort of talked about as one that you could just excise and close. So we did our articulating spacer, which is exactly what Eli, talked about. And I prefer these. I think it makes the second surgery so much easier when they have range of motion. I let them weight bear. Weight bearing is tolerated for these spacers now for me. That's made a big difference, and I haven't seen any issues. And then we go back and reimplant again. For me, he was a younger patient. I went with that sort of hybrid fixation strategy and a short cemented stem on the tibial side with a cone.
Looks good.
Negative pressure wound therapy for these, for me. almost all the time after reimplantation for a week.
I think the other thing that I'll do a lot of these is the wound is often a problem when you've gone back and forth a few times into a knee, and so slowing down the motion, I think, is helpful for a lot of these patients, especially the spacer. I often will keep them straight for a little bit of time and trade maybe a little bit of stiffness for the wound healing, because if the wound doesn't heal, it doesn't matter what their motion's going to be.
Yeah. All right.
I also don't know if you've seen this with your patients. I have many that never actually, they can't tolerate through their medical issues to go back for the replant. And with that type of construct that you put up there, they're happy, they're walking, they're achieving their goals. I don't know if you've seen that as well.
It's a great point. And Carlos Higuera out of, in Florida has published on that, right? It's the 1.5 stage. So, sometimes patients they don't come back, or they come back and they're like, I don't want another surgery. And you just leave that in. I actually have a case coming up where he's had one of those in from somewhere else, and his other knee's loose and infected, and he's like, I just want this. I only want one surgery. I just want the spacer. So, all right. We'll look at this last case really quickly. I think it's just interesting to get your thoughts at the complexity levels increasing. This person had a total knee done in Southwest Colorado in October of 22. Immediately complicated by a fall, wound dehiscence, patellar tendon rupture, had an IND there, then was sent to University of New Mexico, had like an IND and like an explant or something, and then got sent back to Southwest Colorado, and then that surgeon did an IND, and then basically got sent up to us. He has Ife callus, and got sent up to us with, hey, we have this multidisciplinary team. Like, can we save this guy's leg? So we saw him 5 months, essentially, about 5 to 6 months after his primary knee replacement. He had now had about 7 different surgeries. And he walks in, that's sort of what his incision looks like. He has no extensor mechanism, and his knee's basically locked at 50 degrees. Fairly good host. He's like a mountain man, doesn't really see a doctor, but says he doesn't have any medical problems. There's his inflammatory markers. He's not on any antibiotics. I couldn't really aspirate his knee because it's just like stuck. And there's his x-rays.
Did you send this guy to San Francisco? I think I saw him like last week.
I should have, because he's still a problem for me right now. All right, so I guess we'll just sort of get to, the question for this one. We have a primary infected knee that's undergone a lot of things. We now have significant bone loss in the setting of active infection and no extensor mechanism.
Yeah,
not a great situation.
It's the worst problem you can have is an infection and an extensor mechanism, and I think the amputation rate is going to be over 50% no matter what you're going to do. So I think really early on, it's just setting that expectation that without an extensor mechanism and with a now failed infection, it's not going to be great, and just keeping the leg is a win. For this patient, I'm pretty much offering probably 2 options. One is another spacer that stays in forever, or maybe 3 options. One that's a spacer that could stay forever, or go to a fusion, and the other would be an amputation pretty much right off the bat. I would not do an extensor.
You're not trying it.
I don't even try anymore.
Okay.
Yeah.
So you're going to try it?
I
we
think,
know, Mike, you're going to try it.
Well, I don't. I would talk to him about trying. I'm not saying I would necessarily recommend this, but it kind of depends on how motivated the patient is and what they're willing to put up with, and if they want to invest, a year or so into trying. But if you were going to try, what I would do is take all that out and put a spacer rod across the joint with the spacer so it's locked in full extension, and then simultaneously have the plastic surgeon swing a gastrocs flap to connect the extensor mechanism to the tibia, and then come back and make a lateral parapatellar approach around that and move the extensor mechanism gastrocs flap to the side and put in your hinge and then close it. And it is a way of salvaging the knee. The gastrocs comes from the same leg, so if you're going to amputate it, you haven't lost anything.
Okay.
But that's the way if you wanted to do it. And you can go through all that. I'm not saying you recommend it, but a lot of people, if you walk them through this, then they shake their head and say, okay, you know, what Jeff said makes sense, or cut it off, or whatever.
This is the technique where you flip the Achilles round to do the reconstruction.
Yeah.
Eric, anything different?
No, I mean, you got to get to know this guy, but I think the first visit is laying crepe, like Jeff said, and getting a sense of, you know, his goals and his tolerance of being hospitalized and potential for, you know, unexpected readmissions and revision surgeries. But some people really want to save their leg, and you give it your best shot.
Okay.
So I wouldn't say necessarily that the next surgery would be an amputation.
Yeah, so I mean that's exactly what we did. He lives 7.5 hours away from Denver. He was willing to literally stay in Denver. He did all this research himself. He got a skilled nursing facility to let him live there for 6 weeks. And I must have been trained by you, Mike, because that's exactly what we did. Is we went in, took everything out. The tubercle fell off. We sort of put that back together. We swung up the gastroc flap, reconstructed the extensor mechanism, and then IV antibiotics, got him healed. His markers came back down to normal. And then we recently reimplanted him with the exact strategy that Mike said. If you have everything from a medial-based approach to the gastroc and everything, when you go back in, you can use the same skin incision, but then make a lateral arthrotomy and push everything medial and put your hinge in. It's hard to go from a static spacer when you have a flap. It's very tight. So if you ever want to do this, you know, the first thing we did is the fellows and the residents liked it because it's the first time I ever say, cut out the collateral ligaments right now. Just start boving everything so we can get this knee moving. He's having some soft tissue complications right now. His split thickness skin graft over his flap healed, but it was very thin, and we went to reimplant it. It sort of died, and he's having some wound care issues right now. And I think Eric and I were trying to publish that. I called Dr. Ries 10 years ago with this idea when I had a proximal tibia or something. So I've done this. This would be my 6th case in doing that technique, and we're 50-50 right now. So 3 have failed for recurrent infection and went on to amputation. The function of it, however, is pretty interesting. They do have a lag, but no different than like a mesh reconstruction, you know, for just a regular extensor mechanism failure. So it is an option that you have if you have a plastic surgeon that's willing to do it with you.
You know, I do think that most patients, if they had a choice between an AKA and a prosthesis that they kind of flip around when they, you know, swing their hip and walk, or their own leg with their own proprioception in their foot and no extensor mechanism, they do better with their own leg than with the prosthesis.
Yeah, good point. Different discussion when you're talking about failed extensor mechanisms and the outcomes of that and infection rates. Sometimes patients prefer just give me a brace, doc, and I'll just keep my floppy leg that can bend, and I'll walk with a brace.
The flip side to that, though, is that the reinfection rate of a knee implant is going to be higher than a fusion. And so when they look at fusions versus revision knees, that chance of the infection coming back when you keep a joint space is slightly higher. So just kind of, and when the infection and the extensor mechanism are together, it changes it for me. But I agree 100% that a floppy knee is way better than a fused or gone leg.
And we went short there on the femur just in case he does need an amputation, so he can have an appropriate level amputation. Well, thank you. Thank you all for being involved, and thank you all for staying just a few minutes late and get to the reception, Derek.